session. Thank you so much for the presentation. I have several questions, particularly in regards to the deficit. The first question is more on the premium. Before BPJS was implemented in 2013, even from the beginning, people have already calculated the best premium is about $5 per person, and then it's always being the tawar, always being bargained for by the Ministry of Finance. I think my first question is, can you share a little bit what was the dynamics between the Ministry of Health and the Ministry of Finance in trying to find this middle ground? Because as you see now, it's not working with the number of payment is too low. That's the first question. The second question is, when you were doing you mentioned earlier about some health technology assessment, and that's to look at new drugs or new interventions that's going to be implemented in Indonesia. What about the current interventions that are already out there, that's already being implemented in Indonesia that we know for sure it's not cost effective? So for example, maybe something like a very terminal treatment for either renal failure or terminal treatment for heart disease that are very resource draining, that could have been allocated elsewhere. Has there been analysis on the health technology assessment side to evaluate those what's already implemented? Thank you.
Okay, so for the first question, how the dynamic relationship between Ministry of Health and Ministry of Finance, and it is also my personal experience. It is not easy because when we calculated the premium is around $4 per month per person, and the Minister of Finance said no, it is only 1.5, and maximum is that. And I argued a lot, and we were have the dynamic argumentations, and then he could not answer because I said, if you cannot increase and many doctors will protest, it is not my responsibility but your responsibility. And he said to me, so when you started to be the member of legislative body, because arguing like that. So I think finally actually then stop, because we cannot meet the agreement. So we agreed of the non-agreed. Then he said to the minister, and we also said to the minister, and then we have like a strategy. Actually, also if I can say myself and some of my colleagues, when the president SPY visited Ministry of Health, I know that many newspaper journalists will come. So we calculate already 3 types of premium rate. When the Minister of Finance say 1.5, and we said here 2 and 3.5 and US dollar and 5, something like that. So then in the last session with the president, we said, the president, which one you choose among this? Because the Minister of Finance just only 1.5, we do not include it in the choices. So choices is only 2, then 3.5 and 5. So the president and then choose the lowest one, which is 2.5 actually, and then the 2.2. Jadi 22. Then the journalist already captures and announces in the global, in the national level, and then okay, because it's already announced by president, so they cannot go back, and then already president said 2.2 US dollar, around 22,000 rupiah, like that. Okay, because the Minister of Finance always see that health is always spending, and our Minister of Health always see that health is investment. So we cannot meet always. When WHO and World Bank also have the same problems, and they met in Geneva, invited all Ministry of Health from all the globes, and also World Bank invited Minister of Finance. All Ministry of Health came, attended the invitation, and almost no one from the Minister of Finance came to that meeting. So that is not easy. That is again. So the second questions.
Oh, the second question is on health technology.
Yeah, health technology assessment, it is very important, and now we are developing. Although we still trying to develop the human resources expert and the health technology assessment, and now we are developing also the online course for health technology assessment. But for the existing cost-effective procedures or techniques, there is already implemented. So now we are started those who technology or new drug which is will enter to the system. But if they already enter to the system, I think we can do nothing. But maybe in the future.
I mean, he raised the point about end-of-life care.
Oh yes.
If you can solve the issue of how much money is spent at the end of life, then you have done something no other healthcare system has
Right.
ever solved.
My question is, whose life is it?
Right?
If my life, it should be spent more. The problem is, we can calculate. It is not easy questions. So up to how much money, how long we can go, how much money we have to spend. So again, actually by law and by the system, how much money we have to spend. But again, the problem is if we spend like that as your questions, this is the ethical challenge. So actually we can allocate for other minor mild diseases and will be covered for many people instead of only treating one life of the person. But the question again, whose life is it? If it is life of the president, we have to pay how much money we have. So again, I think it is not easy. Yeah.
Sunday, my question is, so you highlighted the problem quite well. So since the inception of BPJS, the demand has increased significantly, but the supply side, the delivery side, is not ready to meet the demand side. And you also mentioned that the supply side is not the problem of the universal insurance carrier, but rather local governments and Ministry of Health. So how do you coordinate and improve the supply side? That's my first question. How do you coordinate
Yes.
between local government and central
First,
government?
my answer is, I'm lucky because I'm not in the Minister of Health anymore. So actually, the questions should be addressed to the Minister of Health, not myself. Because now I moved already to the Minister of Research and Higher Education. Okay, fine.
My second question is actually the poverty data and the data of near poor. And so I did field work past, and I looked at that very intensively. How people entered poor systems and how they enter and how people are hidden and how people are not. And the system is old in the sense that the system is old. So people who are in the poverty list is recorded 5 years prior to what is actually there. So the mismatch between even the person is there or not is not there. And I don't think so. Indonesia does not have the technology to make a direct poverty assessment kind of tool. So I presume, I'm asking, is it because there is the deficit and you don't want to cover so many people that you use the previous list, or so why is that not never discussed the issues of the BPJS?
No, I think in my opinion, it is in the design, it is not really appropriate, because those who know really the condition, whether it is poor or not poor, is the local government. But in this system, local government is not involved. Local government is only observer. So in my opinion, it should be changed. So the design should be changed, how to increase the commitment, involvement of the local government, where they can report. And now Indonesia is developing electronic IKTP, identity card. So by using that, actually not so difficult. But again, the local government should be responsible and should be involved in this system. But unfortunately, now local government not asked to involve. Yeah. Yeah.
It's like it
Right.
like coordinate.
Yeah.
Whereas how do you coordinate?
Yeah, actually by technology is not so difficult again. I think that is the mistake on the design and the commitment, I think.
Yeah.
I-
Just a follow-up question about poor people who are supposed to be insured. So some statistics are about how the poor people want and then recover in money.
So, yeah.
So your figure on one of the big slides you showed that there should be 27 million
Yes.
mistake, but there's actually
92.
92 million.
Right. Now, in Indonesia, actually, sometimes difficult because almost similar conditions. So when we classify this as the poor, what are the criteria? For example, the weight of the land of the house, for example, should be every person should be more than 8 meters. So when they have 5 people in one house, should be 5 times 8 should be 40 meters, at least 40 meters. If less than that, it is one criteria of the poor. So other criteria is they have to have the money less than $20 per person per month. So if 5 people, it means $100 per month. One household, it is poor, something like that. So there are 22 criteria of the poor. But anyhow, because it is almost difficult to differentiate poor and near poor, or near poor and near rich, so then the government increase up to 92 million people are covered and paid by government.
That seems reasonable.
Yeah, simple.
Yeah.
In my opinion, it should be add more.
Yeah.
But the problem is whether the money is there or not.
Right.
But I think actually the money is there, especially when we are, relate to the tobacco company, because tobacco company in Indonesia, almost the richest number 1, number 2 is the person who have a company for cigarette.